for this discussion today, the American Enterprise Institute and the USC Brookings Schaefer Initiative for Health Policy. At the outset here, we also want to thank and acknowledge support for this event provided by the Robert Wood Johnson Foundation. I think we're all very aware of the challenges our hospitals have faced over this last year and continue to face as a result of the pandemic. But even before the pandemic, the Hospital Insurance Trust Fund financings faced depletion under current law. Last month, the Congressional Budget Office estimated that the trust fund would be depleted in just 5 years, in 2026. And I've seen estimates that should this happen, there would be a 17% reduction in Part A payments to hospital providers. Should this happen, how would hospitals respond? What would be the impact on the nearly 70 million Part A Medicare beneficiaries in that year, 2026? More importantly, what can policymakers do to avoid the trust fund's depletion, or does it even matter? To answer these and other questions, we have two panels. One that will be with health experts here first, and then we will follow with another panel of high-level congressional health staff. And to moderate this discussion, we are very fortunate to have Dan Diamond, the distinguished health reporter at the Washington Post and formerly with Political. Before I turn this over to Dan, we have a very large number registered for this event today, and we will try to leave time for questions, but you can imagine that we'll not be able to get to all your questions. But you can submit these questions via the live chat on our YouTube or Facebook or on Twitter using hashtag BPC Live. And then one final note, our joint BPC Health and Economic team will be releasing shortly a white paper on this very subject, concluding that the longer we wait to implement a solution to the trust fund's depletion, the less impact it will have on restoring its solvency. And look for that to be posted on our website in the next few weeks. So with that, I'm turning it over to Dan.
Thank you, Bill. And thanks all for watching this panel today. If you're anything like me, you've spent the past year obsessively focused on one story. How much money does Medicare have left? It's just kept me up at night. In truth, the Medicare Trust Fund is an issue that I have spent years writing about, but have barely thought about since the pandemic began. But there is light at the end of the tunnel with the pandemic, I think we all hope, which means it's time to start thinking again about those long germinating policy issues that aren't just about COVID. And when the folks at the Bipartisan Policy Center asked if I'd like to moderate these panels, selfishly as a journalist, it seemed like a chance to double up, to quiz experts that I knew I would need to start talking to again for future stories. So you will hear my questions to them. You can ask your own by using the live chat on YouTube or Facebook or on Twitter with the hashtag BPC Live. So let's get to this first panel with Matt Fiedler of Brookings, Jim Capretta of AEI, Kathy Budo Principal of Kathleen Budo Consultants, Mark Miller of Arnold Ventures, and we will start with this, Jim. I've been covering healthcare for years. The Medicare Trust Fund is always running out of money. As Bill noted, things seem especially dire with projections for the Hospital Insurance Trust Fund. What is the single best proposal to address Medicare solvency issues? And what is the most realistic one, understanding that the two might not be the same?
Well, thank you, Dan. Great to be with you. And thanks to BPC for hosting this. I'll be quick about this because we got lots of good folks behind me here who have some things that they should be able to get onto the table too. Look, I think the Medicare Trust Fund, the HI Trust Fund, is a signal to Congress and to the policymaking community to take a look at the financing of Medicare and figure out what's going on. Obviously, solvency of that particular trust fund is important, but it's really related to bigger fiscal questions. The Medicare is related to the major challenge the country is having with healthcare costs generally, and the aging of the population. So I try not to just narrow this down to just technically adding a few more years to the HI trust fund. I'd say that from the outset. So the best idea, I think, is something I've long favored, which is to bring some cost discipline to Medicare more generally. And I favor doing that through a competitive approach, something called premium support. I would definitely not put this on the politically viable high list, okay? There's a lot of reasons people haven't done it in the past, but it's a systematic way of bringing some cost discipline to the program through basically competitive bidding and people finding new ways to cut out costs and lower prices. And I think there's a lot of evidence that it actually would work. CBO says it would lower costs by about 8% when fully phased in. And that's probably a conservative estimate, as CBO often is. So I think I would say premium support is the place to start. Now, in terms of what's most politically viable, I think Congress is really inclined to go toward incremental and marginal and try to get the trust fund a few more years so they can go home and tell their constituents, hey, we added some more years to the HI trust fund. And to do that, I think probably the most likely scenario is they'll cut payment rates for some of the providers that look like they're overpaid. And there are some. So maybe even generally on the hospital side, they might say, hey, let's take down the payment rates in the future years by a certain percentage. And that always can save a fair amount of money. And then they'll try to pair that with some kind of new revenue source to also add to the revenue side of the equation, perhaps looking particularly at high income people. So anyway, those are a couple of thoughts to kind of get the conversation started.
Mark, I'm curious if we can make this real to this administration and this White House. President Biden, Democrats have their own set of proposals. The president has proposed, for instance, lowering the Medicare eligibility age. When you think about the proposals that are likely on the table, do you see any that would significantly affect Medicare solvency in the coming years?
I mean, speaking to the administration ideas first, if you're talking about lowering the eligibility age, that obviously is going to put a greater stress on Medicare. However, I think the way those ideas have been talked about is to create a separate risk structure for the new buy-in. So it may be a separate problem from the existing problem. There have been talk about the notion of lowering drug prices and getting savings there. But again, if those savings were devoted to Medicare restructuring or trying to bail out the more immediate problem on the trust fund, maybe that could be a help. But the discussions are about using those dollars to fund coverage expansions. And that's more what I think the administration is thinking about, is coverage expansions, as opposed to thinking very directly about this problem. Just a couple things about what Jim said, because I think there were a lot of things that he said that should be followed up on. I think he's right about thinking long-term premium support, and I think he would also agree that restructuring and rethinking the trust fund structure in general makes sense, because we have this sort of smoke alarm for HI, or the Part A trust fund, but then we have the Part B trust fund that's not really a trust fund and heavily deficit financed, and there's no smoke alarm for that, and there's probably some restructuring there. But I also think he's right that they're likely to think incrementally. And I think he's right that they would think, and I would actually agree if they're going to take an incremental approach, that there are reductions to payment rates that would make sense. Home health, there's some very obvious targets in managed care, site neutral payments in the hospital setting. And if they think about revenue, there are more progressive ideas like, high income earnings that are not taxed that could be brought in. And so to stop, or to close, the notion of, I think the administration is really thinking about expansions. I think Jim is talking about restructuring, but that's probably a longer term prospect. And even in that context, I think they'll have to think of short-term fixes that would involve, payment and potentially some new revenue source. I'll stop there.
Kathy, I have a question for you that I want to ask the audience too. A lot of the proposals that we just heard from Jim, from Mark, they've been out there for some time: premium support, cutting payment rates, even thinking about restructuring the program and pushing Part A, Part B together. What is a zombie idea, a proposal that's been out and circulating for a long time, that you think we should just kill off at this point when talking about Medicare solvency?
I think all ideas should be on the table in talking about Medicare solvency. I think the only zombie idea would be one that, really doesn't have any chance of passing, but some of the most bold and innovative ideas are those. So I wouldn't be willing to kill anything off at this point. I think it makes sense, since I was around when the first insolvency was predicted to be in the 90s, and Congress has managed to incrementally improve the HI trust fund over years with incremental changes. That incremental changes are probably what's going to happen, and are the most acceptable, including things like unified post-acute care, some of the proposals that Mark and Jim were talking about. And I'd like to actually see a movement toward attacking the issue of high-cost patients. So high-cost patients actually account for between 60 and 80% or so of annual Medicare costs. They're drivers of costs. We haven't done well in managing their costs. And I think we ought to look at things like BPC has proposed, which are sort of non-clinical benefits that will actually advance the wellness of the population. And I think there are aggressive ways to do that. So I actually think all proposals should be on the table, but the ones that ought to be pursued are the ones that are actually going to pass.
Matt, you've just heard experts talk for 10 minutes about different proposals to address Medicare solvency. Are we thinking too much about the issue of Medicare solvency and not enough about things beyond the trust fund?
So I think if we get too focused on the sort of literal Medicare trust fund, we're going to be doing this conversation wrong. If your only goal was to solve the trust fund, Congress could transfer funds from the general funds into the trust fund and the problem would be solved in perpetuity. So I think we should really be having a conversation. And I think both Jim and Mark in their comments picked up on this. We should be having a broader conversation about how do we improve health policy and fiscal policy broadly. And I think there are really two ways in which sort of a trust fund centric focus can lead us astray. One is, I think as both Mark and Jim mentioned, some of the sort of best ideas for saving money, even just within the Medicare program, actually primarily would produce savings for parts B and D of the program. And I think it would be a shame if we have a whole discussion about Medicare solvency and those two whole parts of the program just fall out of the discussion. I also think there are plenty of places Medicare can and should become more efficient. There are places both inside and outside of Medicare where we should be spending more on healthcare. And I think, again, having a whole conversation about health policy that doesn't touch on any of those would be a lost opportunity as well. I think that's particularly true because in practice, I suspect that, a desire to finance improvements in coverage, either inside or outside of Medicare, may be a more plausible motivator for money-saving changes than what is the fairly sort of artificial problem of HI insolvency.
We're already starting to get questions from the audience. I want to make sure I'm incorporating as many as possible. Mark, I think I'm going to ask this one to you from Lisa. Does cutting reimbursement rates risk exacerbating the problem of availability of services to Medicare patients versus private pay patients?
So in and of course, we very limited time to talk about these things, but in the ideas that we outline for incremental change in a Commonwealth piece, and I don't know if I'm not supposed to mention Commonwealth on a BPC presentation, but I apologize. But the specific proposals that we put on the table were really scoped out, and this is with Erica Socker, designed to be reductions that in our view, would not have an effect on the beneficiary, where payment rates were either very excessive and are known to be excessive, or you have things in the managed care industry where people are upcoding, situations like that where they were scoped specifically to avoid access problems. And I want to add one other quick thing. Kathy made the point about incrementalism and what is likely. The other thing to keep in mind on incrementalism is there were changes that were made to accommodate COVID that could be, revisited now that hospitals seem to be recovering. So the sequester was removed. There were accelerated loans made out to providers. And if incremental steps are taken, those kinds of ideas should also be revisited.
Dan, this is Kathy. I just wanted to add to what Mark just said, that both the post-acute care, unified post-acute care, and the Part D prescription drug changes, which would be incredible savers, it will actually benefit beneficiaries. In other words, I don't think we'll see any adverse impact, and both of those will correct distortions that really need to be addressed.
I think BPC will have to edit out all the Commonwealth plugs that we just heard in the past few minutes for all the YouTube fans who are catching this tonight. I have a question for you, Jim. I want to go back to this point of what we do post-COVID and the proposals that could be ditched or the incorporations of policy around COVID in a post-COVID world. As Mark was saying, how big a difference would that make, and how politically palatable would those be in your mind?
Well, I think, we're still in the midst of this crisis. And so probably not right now wouldn't be the time, but I could see 6 months from now, 9 months from now, if this thing starts to get a little bit more in the rearview mirror, people are going to say, well, do we need to continue with some of these concepts and policies and ways of thinking about our payment structure, that as if we're still in the midst of a pandemic? And so I agree with Mark. I think that, they could probably reinstate the sequester, and I don't think there'd be much effect on patient care at all. There wouldn't be any, in my judgment. And, this business of the advanced payments that were made to the hospital systems that the hospitals now want forgiven, honestly, I think we probably could ask them to repay it back and take it against future payments in a year or two, and it wouldn't make much difference in terms of their ability to take care of the Medicare population. In fact, I don't think it would make any difference at all. So I think post-COVID, we should be putting more discipline back into the system. That's not to say, however, we shouldn't, as a country, be better prepared for future pandemics and making sure we're more resilient in a kind of systemic way instead of ad hoc way. But that's a separate conversation.
Matt, you were talking about the long-term structural changes that could be applied to how we think about Medicare and broader healthcare spending. What do you make of what you just heard from Jim, Kathy, Mark?
So, I mean, from the perspective of COVID, I completely agree. I think, the things we didn't like about the healthcare sector in 2019 were the result of a sort of set of structural policy and economic forces and once we get past COVID, those factors are going to reassert themselves. So that I think in many ways, 2023 is going to look, the sort of set of problems we're trying to solve in 2023 is going to look in many respects a lot like the set of problems we were trying to solve in 2019. To be very concrete about it, I'm not aware of an argument for why the fact that we had a pandemic in 2020 and 2021 is a good reason that Medicare should pay hospital outpatient departments more than they pay for the same service in a physician office come 2023. There's no logical connection between those two things. So, I think it can be overstated how much the pandemic should change how we think about health policy going forward.
We have a suggested question from someone at BPC, and it's a question that will require a quick answer, a good idea or bad idea. So Congress is about to pass legislation later this week that would extend the current suspension of the sequester. Good idea or bad idea? Kathy, you first.
Good idea.
Jim.
Bad idea.
You know, I'm a bad moderator. I should have said quick answer and why. So Jim, why is it a bad idea?
Then you can go back to Kathy and get her bad idea, because I think there's plenty of give in the revenue streams of these systems, that creating a precedent where we're going to go back to the pre-sequester levels, I think it's better to kind of move forward. And if there's struggling systems out there, deal with it on an ad hoc basis rather than just across the board paying out a lot more money, which I don't think is necessary.
Kathy, good idea and why?
Well, just off the top of my head, having more money in the system right now feels like something we need to be doing. I find myself agreeing, though, with Jim that it creates real problems downstream. So I think it's a more nuanced answer than you're asking for, Dan.
Well, I'm a mere reporter. We don't seek nuance. We seek
right.
Yeah.
Yes or no.
Mark, good idea, bad idea to extend the current suspension of the sequester?
Yeah, and I mean, picking up with Kathy's last point, it's more nuanced than that. I agree, and even I think the notion of the 2% sequester that was in place, we may be getting close to a point where we can put that back in place. I think the piece of legislation, though, is talking about a larger sequester hit that's more broadly based off of the PAYGO. And, you know, again, you could imagine splitting some difference here and saying that there is some sequester that should go back into place, but perhaps not all that's being considered there. But I'm not 100% sure I have the percentage right in my head. But I'm not going to say yes or no, just on principle. So.
We'll let panel 2 do that.
Well, this is helpful from a reporting standpoint, because I've now canvassed and gotten 3 different opinions, which I could put in a row. But Matt, why don't you break the tie? What is your stance? Good idea, bad idea, extending the current suspension of the sequester?
You know, I think for something short term, it might not be what I do, but I don't think it's the end of the world. I think the concerns are very much what others pointed to, of, you know, do you set a precedent where the sequester never comes back over the long run, which I do think would be problematic and hard to justify in terms of the benefits that would generate for patients.
Just a clarification, Dan, if I could. Mark's right. I mean, the bill they're actually going to pass is suspending, I believe, the sequester associated with the COVID response bill, and which is different from the underlying 2% sequester, which had been there way back to the Budget Control Act of 2011. And so I'd put the 2% back in, but I don't, the bigger cut that's associated with PAYGO enforcement, I think is going to would be too much.
Better said.
We have a number of questions coming in, and I want to make sure that we're getting to as many of them as possible. So the next one is going to be Kathy and Jim. I'd like to ask this to both of you. From Rebecca, we spent at least 15% more on Medicare Advantage plans, but are we really getting more? And is it time to reconsider privatization? Kathy,
well,
what do you think?
First of all, MA plans has been called privatization, but I think what the caller or the writer is getting to is it time to look at more competitive approaches to setting payment rates for Medicare Advantage? And I've been a strong proponent of that for a long time, ever since HCFA, before CMS, tried to do competitive pricing for MA plans. I think it's the right way to go. I don't think there is justification for paying more to MA plans, and I'd like to see it move more toward competition. It is also one step closer to premium support once we've gotten to a more competitive MA rate setting approach. One could consider moving to premium support, which I also support.
Jim.
Yeah, I'm a big fan of competitive bidding. I think we would, if we had bidding, we'd start to see much more clearly what the actual price of covering Medicare would be if it was established on a very uniform, standardized benefit and you had to bid against that. then the price difference, the premium difference, would be entirely about how efficient you are at delivering that defined benefit package. So I'm very much for competitive bidding. I do think we need to think carefully through how to incorporate, and then this makes all the difference, fee-for-service into this. Remember, MA plans, yes, they get paid more by Medicare than fee-for-service, but they've demonstrated pretty consistently over a long period of time that for the same benefit package, they will be less expensive by a wide margin. So if you do this, then you would have out-migration out of more efficient plans into less efficient fee-for-service, which doesn't make a lot of sense in my view. And so bring fee-for-service into it in a way that's controlled, try to protect the beneficiaries from large shocks in their premiums. But I don't think it makes a lot of sense to say, you know, what we really want to do is have big, expensive fee-for-service in urban areas that's totally unmanaged with use that is very high, and then say, you know, well, at least we're not overpaying the MA plans. You know, I think that's a wrong way to think about the problem we're facing.
Dan, one last comment on that. MedPAC has done some work, well, Mark was there actually, that shows in some cases fee-for-service would be the lower cost plan. So it isn't a simple matter of trying to make these two plans competitive, but it's an important step. And I think the question is a really good one. We have to take baby steps first to really make MA plan rates more competitive.
Matt, the next question from the audience, I'm going to direct it to you. It's from Gretchen. How might the concept of direct contracting affect the Medicare Trust Fund?
So, I mean, the various direct contracting models that the last administration was looking at, I mean, these are really an evolution out of the ACO models that existed before them. And, you know, without getting into the details of these particular models, I think there is some scope for ACO models and similar models to reduce Medicare spending in ways that don't harm beneficiaries. And I think we should be thinking about ways to use those models more broadly going forward. Frankly, I think the fundamental problem we have right now is that all of our existing payment models are purely voluntary for providers. And I think that forces Medicare to design those models in ways that either create very weak incentives or provide substantial windfalls to the participating providers. So I think if we're going to use these types of alternative payment models to save substantial money for Medicare going forward, I think we're going to need to sort of rethink our overall strategic approach to them.
Mark, I have a question for you, also from a Mark. Perhaps you asked this to yourself, which was very strategic. Are there any viable proposals to update graduate medical education, GME policies, to drive savings?
I just want to say I'm not clever enough to give myself this question. That wouldn't happen. So the answer is yes. And I think this issue supersedes the solvency of the trust fund. This is something that MedPAC and at a time when I was there that we thought about. And there are a few things I would say, although they indirectly could help with the trust fund. One, I think the indirect medical education rates are set too high. Two, I think that if there is residency support, it should be much more tied to the performance of the teaching process, whether it's getting people out of the hospital setting or practicing evidence-based medicine. But there is a philosophical problem of why we created graduate medical education that was specifically tied to the HI trust fund and the reimbursement rate for a hospital stay. If you think about graduate medical education, it's a broad societal good. It educates doctors for the entire system, and why it is narrowly tied to this trust fund and an admission to it for a Medicare patient doesn't, in my mind, make a lot of philosophical sense. So the answer is yes, there are viable policies. I probably didn't do a good job just this second, but they exist.
We do have another panel that will come after this one, though we have some time before they join us. I thought, as a way to wind down this panel, understanding that there are so many things we could not get to, the next panel will feature folks who are congressional staff. When the four of you are looking across this next year, what are your best predictions, expectations for what you think will happen on this issue? Why don't we go in an order of Kathy, Jim, Matt, and then Mark. So looking across this year, Kathy, we'll go to you.
My guess is the issue of Medicare and the trust fund won't be the reason Medicare comes up. Medicare will come up because they're looking for savings, whether as part of a larger budget package that, say, begins to address infrastructure issues or other issues related to the budget. Medicare is the cash cow that is often pulled in when savings are needed. Having said that, there's no question that there are opportunities both to get those savings more broadly and to improve the Medicare program. So I expect some of the incremental changes, payment improvements, reforms we've talked about will come up.
Jim.
Yeah, I basically agree with that. I think it's possible that Congress will be tinkering with some Medicare things later this year, but it won't be because of the HI Trust Fund. It'll be because they want to do something on drugs. Maybe they want to do some things that the president campaigned on in terms of Medicare improvements, adding, the House passed last year a dental and vision benefit. I mean, there's a lot of pent up desire to do things in the program that have nothing to do with HI solvency. I think they'll push back HI solvency maybe to a later point when they are sort of forced to do something and Republicans have to join them and do something more controversial. But I think for now, the agenda is likely to focus on other matters that they're worried about in Medicare that are kind of unrelated to HI solvency.
Matt.
I basically agree with what Kathy and Jim both said. I think to the extent there's legislation passed here, it's going to be motivated by other things. And, as I said at the outset, I think in some ways HI solvency is the wrong problem to be thinking about. The right question to think about is how do we get more value for our healthcare dollars? And to the extent those packages manage to do that, I say more power to them.
I appreciate that you don't think Medicare solvency is the right problem, and yet you joined this panel anyway. It's very, very.
Sometimes you got to challenge the prompt.
And Mark, your thoughts on what's coming next?
Yeah, I wish I could think of something creative because I fundamentally agree. I think the Congress's and the administration's focus will be on coverage. The Medicare drugs will be one of the ways they think about financing that, and that may also lead to other kind of Medicare considerations. I don't see the trust fund solvency as being the on-point issue, although there are certain members of Congress who are beginning to point to it. I also think a key indicator will be when the trustees report comes out and what year they peg it at precisely. And then I think that could drive some additional attention. So largely consistent with what the other panelists said. I'll be curious to see what the focus looks like when the next trustee drops.
Just out of curiosity, you're all folks who have spent a lot of time thinking, writing about this issue. In your gut, do you think we will get a long-term fix to Medicare solvency issues in your lifetime? Will that happen? I guess I could direct it to a specific person, but maybe your silence is the answer enough.
If health spending ever stops growing faster than GDP, yes, because the problem will solve itself. And if not, no, I suspect we'll be dealing with this every decade or so.
I look forward to doing
I sort of think just one last thing I'd say is I think the country is headed toward a fiscal problem of some sort, of some dimension. It's hard to put exactly what it'll look like and everything.
But wouldn't you say that though? That's kind of your corner.
That's my thing. Yeah, I always say that, right? But I mean, I do think that you can't go on like we are. I mean, just look at the projections. So something will give. That doesn't necessarily mean it'll be Medicare reform though. It might be just we're headed toward a lot higher tax rates.
Well, perhaps we can leave it there, and we'll just have to come back and do this again in 5 or 10 years because it will be an issue still with us. Jim Capretta, Kathy Budo, Matt Fiedler, Mark Miller, thank you all so much. We will now begin to transition to our second panel with Hill staff experts. And I believe they are on now or coming on. First, Amy Hall, Staff Director for the Subcommittee on Health, the House Ways and Means Committee. And Stephanie Parks, the Staff Director for the Committee on Health, House Ways and Means Committee also. Amy is in the majority, Stephanie is in the minority. We may have one more panelist joining us to make that a trio, but not quite yet, I think. Amy and Stephanie, welcome. I see you on my screen. I'm hoping everyone else can see them too.
Thanks. And Sean just joined too. I can see your video.
Oh, great. And Sean Bishop, the Chief Health Advisor for the Senate Finance Committee, majority staff. So I don't know how much of that first panel you just heard, but clearly no one solved the Medicare solvency crisis. When you are looking in your roles as Hill staff at what lies ahead, I'm curious, and we can use this as a jumping off point to begin the next 15, 20 minutes of conversation. Do you see an opening for a serious conversation about Medicare solvency and associated reforms? Stephanie, why don't we start with you? You're in the minority, so your view will be a little bit different, I think, than Amy and Sean.
True. And Amy and Sean can tell us what's actually happening. But thank you for having me. And again, these are kind of my opinions, not the opinions of my boss. But I think we can say from a Republican perspective, it's something that we definitely want to work on. In a former life, I worked for then Budget Committee Chairman Paul Ryan. So I think, we've been thinking a lot about these issues for a long time about structural reforms to Medicare. But I do believe I agree with kind of the conversation at the tail end of the previous panel. I think Jim mentioned that perhaps the work that we do on Medicare in this Congress will be more in the context of finding savers and offsets as we've seen our Democrat colleagues start to move legislation and take advantage of their majority in the Senate. So I would presume that would be the context, but we would be very happy to work with Amy and Sean on any kind of structural reforms to Medicare that they would be interested in.
Amy, are you ready to work with Stephanie on those structural reforms to Medicare solvency?
Yeah, I mean, I think I would just start by saying that, this shouldn't be a partisan issue. It should be bipartisan. It's a challenge that, it faces all of our constituents. It wasn't created by Democrats. It wasn't created by Republicans. And, I think at the end of the day, working together is really what's going to get us to the best place in the long run.
Sean, what is the view from the Senate about openings to discuss Medicare structural reforms?
Hi, that's a great question. I guess I have a couple of thoughts there. I do agree with Amy and Stephanie that it's something that our bosses care a lot about because Medicare is so popular and it's such an important program for the beneficiaries who are served by that program. But really all of us are served by that program because our family members have, really good healthcare coverage through it. So it affects all of our lives. And I don't think there's one member of Congress who doesn't want Medicare program to be successful and to be viable. So it is a bipartisan issue, and it will be, and it should be. So I'm hoping that that even this next issue that we're thinking, the next challenge that we have in front of us with the trust funds will also be a bipartisan issue, as Amy and Stephanie said. I will say that the trust fund itself is not something that I think everybody thinks about every day. Dan, I think you opened up your this whole conversation saying that, like, does it keep anybody up at night? It's not top of mind because Medicare is functioning, Medicare is working, people are getting their benefits. So we have a little bit of time to think about this. It's not a crisis on our doorstep right now like the pandemic is. So I feel like the pandemic is really taking up a lot of attention. And until we sort of get more, through the pandemic, just through the pandemic and into another new normal, then the trust fund is still going to be something that's off in the distance. That's what I'm seeing.
Sean, I'm curious. We've just gone through the rescue plan negotiations. there are so many COVID-related issues. What percentage of your brain power is devoted to Medicare trust fund right now? Is it 10%, 5%, 1%?
Well, I mean, that's a good question too. I guess I'll just say two things to that. We're always thinking about the Medicare program because it's something that Congress manages. That's a program that Congress is really responsible for. So we're always thinking about the program. We're always thinking about how it's operating. Not a day goes by that we don't do that. I'm looking at my colleagues. Thinking about the trust fund and how the accounting for it operates is different. It's more administrative. And I think that we don't necessarily think about those on a daily basis because that has been working well, you know. And so, yeah, 100% of my time is on Medicare. And if I'm not thinking about Medicare, I'm thinking about Medicaid, thinking about healthcare, you know, writ large. And Medicare is always a part of that. So we're always thinking about how to make this program better.
We are still taking questions through the live chat on YouTube and Facebook. And then if you're on Twitter, you can use the hashtag BPC Live. I think I got that right. Yes, BPC Live. I want to go to you, Stephanie. We talked a bit about this in the first panel. It's not just about the hospital insurance part of the trust fund. Medicare is obviously so much more. Republicans have focused in quite a bit on Part D, on reforms to the drug program. When you think about ways that Republicans, Democrats can work together, do you really see a path to doing Part D reforms together?
I think absolutely. I think one thing you can note of last year, even when we had our own sort of contentious drug debates and thought about the role of the federal government and Medicare in setting drug prices, one thing that was consistent in what Senators Grassley and Wyden worked on, HR 3 in the House for the Democrats and HR 19 for Republicans, was fundamentally reforming Part D and looking and trying to put an out-of-pocket cap for seniors who, you know, could face exponentially high drug costs if they ever kind of reach that tier of a chronic illness. We all kind of have that provision. We had different numbers. We maybe had slightly different approaches, but I think there's a lot of stuff we disagree about probably in the drug space, but Part D reform and the out-of-pocket cap seems to be kind of the perfect combination where there is a way to save beneficiaries money, there's a way to save the taxpayer money, and there's a way to make this program work more effectively. And I hope that seeing how that policy was the center of the Venn diagram between our three provisions, that is something we can work on as soon as we kind of defeat COVID and move on to hopefully more bipartisan things in the fall of this year.
Amy, who is the smartest Republican on Medicare issues?
Well, I mean, Stephanie is sitting right here. What kind of a question is that?
Present company excluded. Present company excluded.
Right. Present company excluded. Who is the smartest Republican on these issues? I mean, you know, there are plenty of people who have thought about this for years. There are people on the Hill. There are people off the Hill. You know, and I would just say, like, at the end of the day, what really matters is a commitment to get policy over the finish line, you know, and a working relationship. And so we have an almost entirely new cast of characters, this Congress, other than Stephanie and I think, you know, who are going to have to take on this challenge. I should say from Chairman Neal's perspective, right, we already know beneficiaries have an excessive cost burden on the Medicare side. That's the whole reason that in HR 3, we added dental, vision, and hearing benefits to the program, because it's out-of-pocket costs like that that can really negatively affect patient access to care. And, you know, even if you go into the CBO estimate on HR 3, and you look at what they said about lowering prescription drug costs, there's a line in there, right, that says, we expect demand to increase when you make the cost of care more affordable. So I think that's something else we're going to have to think about as we go through this. You know, if we are lowering Medicare spending, that is ultimately, everybody knows at the end of the day, but people don't really think about it this way, going to benefit the patients too. They will see lower co-payments, co-insurance, whatever you want to call it. So I think I kind of took your question and I went in a totally different direction. But, I think as long as we have shared goals and shared values here, we will be able to come together and get something over the finish line that's both good for the program and good for the beneficiaries.
Taking a reporter's question in a different direction is a skill in Washington, D.C. And often it leads to a better answer than the question that the reporter was initially seeking. Sean, I am curious from the Senate perspective. Amy mentioned the new cast of characters in the House. Certainly the Senate is flipped. It's a different world than it was just a few months ago. What does that allow you and your team to do this year that will come back to affect Medicare and the trust fund?
Mm-hmm. Right. So when the Senate flips, that means that in this case, the Democrats have the majority and they control the agenda, basically, in the Senate. So the leadership office, Senator Schumer, and then the committee chairman are really putting forth their ideas in terms of what are the important policy problems, what are the important problems in people's lives that they want to try to address. And so that's really what this means, is that there's going to be a spotlight shown on different issues of the day. And for sure, Democrats are interested in coverage. I think that was mentioned on your prior panel. They're always interested in improving Medicare and making sure the program's working for the beneficiaries that it serves. I just want to say real quick, taking this opportunity to talk about what Stephanie and Amy said about finding a way to improve the benefit design. And I think that is just a real win-win. It's a win for the program. It's a win for beneficiaries. And to the extent that we can do that, I think Congress is going to be motivated to try to find areas of common ground that actually improve the program for beneficiaries. I'm a little bit worried about some of the ideas that are on the table. This is not a criticism of any person who puts this idea on the table, but major reform of the Medicare program necessarily would involve, or for most of the ideas that involve major reform of the Medicare program would involve changes to the benefits or impacts on benefits. And we have to be very careful about those impacts, because beneficiaries, would depend on this program. And there are some improvements that need to be made. So anything that we do to redesign the program or the trust funds really needs to keep in mind how it's impacting the benefits that beneficiaries have, and that they utilize every day. So that's going to be our focus, is how much change do we need to address the trust funds? And then what kind of benefit design actually improves the program for the beneficiaries?
I understand that there are a lot of questions coming from the audience on Medicare for All, which is in the Venn diagram of this panel. There is obvious crossover in the Medicare issue. And also, we're very near a moment where House progressives are going to introduce their Medicare for All legislation again. I do have a question as a reporter here. What is the plan to cope with or to address progressives pushing Medicare for All? Is there going to be a hearing in the Senate Finance Committee? Is there going to be a hearing in Ways and Means on Medicare for All in the near future being the next 3 to 6 months? Amy.
So at the moment, our committee schedule is up for the next weekish or two. We have not noticed any hearings on coverage related issues. I'll give you the answer that I think is the best way to think about this. Democrats have long been staunch advocates of expanding coverage. They've been staunch advocates for ensuring that all Americans are covered. I was here for the creation of CHIP when all of the conversation was about ensuring that kids could get covered. We had millions and millions of uncovered children who were eligible for Medicaid and CHIP and were not enrolled. I was here wearing a different hat during the ACA coverage expansion. We had millions of Americans who were, dying, literally, because they couldn't access the care they needed because they weren't covered. And Democrats pulled together and came up with the Affordable Care Act. I think it's been, a great success. This is a fundamental principle of our party, of our caucus, covering Americans. And as you guys know, you just have to take a quick walk through the congress.gov list of bills. Democrats have lots of ideas of how to do this, right? It's Medicare for all. It's lowering the eligibility age. It's a Medicare buy-in. It's a public plan. It's a Medicaid buy-in. It's expanding the Affordable Care Act, right? There are a gazillion options out there for Democrats. And I think the best option for us is the one that our caucus as a whole, that our party coalesces around and can move forward. Because at the end of the day, what's important is helping Americans and helping our constituents. So another long-winded answer.
I like that you pointed to what's been noticed, because only what's been noticed in the next week is what's going to happen from Congress this year. Sean, I'm curious about Medicare for All in the Senate. I don't recall a Senate Finance Committee hearing on Medicare for All. There's clear passion from progressives on having this issue heard. What would the Senate Finance Committee do on Medicare for All this year, if anything?
And that's a good question. I guess I'm going to take just to be honest with you, that our hearing schedule isn't fleshed out either. So we don't have a set of hearing topics for the rest of the year. So I can't say whether it would be in a hearing or not in a hearing. Members can always bring up, Medicare for All in any hearing that we have, of course. And some members of the committee have Medicare for All type proposals. So there's no shortage of opportunities to speak about Medicare for All. Whether we're going to have a hearing focused on it, I can't say, because we just haven't finalized our hearing schedule. I will say that this week we have a hearing tomorrow focused on nursing homes and the COVID impacts on nursing home residents. So that's kind of the focus that we have right now, is just understanding some of the racial disparities that we've seen in nursing homes, and some of the problems that we've seen with nursing home quality, and how we're going to fix that problem. So that's kind of where we're focused this week, as you're saying, and what we do next month and so forth, it's to be determined.
I will be watching closely. Stephanie, I feel like in covering Medicare-related issues, each side will always seize the opportunity to paint the other as cutting the program if there is a window into making that argument. How hard does it make the job of thinking about reforming Medicare when that politically explosive issue is looming around the corner?
Well, I think it's a great point. And as I mentioned before, in a previous life, I worked for House Chairman Paul Ryan, who had a picture of a lookalike, throwing someone off a cliff. So I remember distinctly that it's definitely weaponized a lot, and we're no strangers to that across healthcare. But I think to Amy's point, that's why it's so important when you have people who kind of have shared values and want to work together and kind of hold hands and jump together. And, we worked so closely and well during surprise billing, and was able to work with other committees and get something across the finish line there. And so if we can find areas of agreement and hold hands and jump, that seems to be the best place for all of us to work. And to go back to something that Sean said of this, there's something to be said for looking at the program design and looking at the benefit and kind of what's lacking for patients, and also what's good for the program, and looking at solvency. And not to sound like a broken record, but that's why I keep coming back to Part D out of pocket. There's an actual path forward there, I think, of win-win for the program itself and for beneficiaries that we can all agree on, that all of our bosses have bills on it, and it's something that we can move forward. And when we hold hands and jump, those are the politically, those work, they stay, they stick. And I think they're important for the program and important for Congress. So hopefully we can kind of find those areas of agreement and kind of neutralize a little bit some of the political rhetoric that comes out of this debate.
Just to make sure that I'm balanced, I asked earlier, I think I asked Amy who the smartest Republican was on Medicare. Who's the smartest Democrat?
I'm ready, Richie Neal. But we're lucky, truly. I've been able to work with both Amy and Sean's bosses. I think are very genuine and care a lot about this. Ron Wyden worked on something with Paul Ryan all those years ago. Mr. Brady and Mr. Neal had a really successful surprise billing work, working on GME, a lot of Medicare stuff at the end of your package. So I'm lucky. I think we do have a new cast of characters, but I'm partial, especially to finance and ways and means. And I think we're lucky that I think Mr. Neal and Senator Wyden get it. They get what we need to do, and they get the politics around it. And so I'm optimistic that together we can all kind of move forward on, maybe it's not the biggest win, maybe it's not the thing that's going to have 75-year actuarial success for the program, but it is something that can help patients and to help kind of push out that expiration date a little bit. Hopefully we can work on that together.
Sean, I asked a question of the first panel that Kathy completely rejected the premise, but I'm going to go back to it anyway because I'm stubborn. And it was which ideas are zombie ideas? Is there a proposal? Maybe I can make the question even more direct. Is there a proposal that you hear again and again about Medicare reform that you just wish that proposal would die? You don't think it makes any sense?
I'm going to go out on a limb and I'm going to put one out there. And that's raise the eligibility age to 67. I'm going to say that one should not really be walking around. It's in this environment. That's not where we're going. And so maybe no, I don't know if anybody in your panel spoke to that, but I do want to also just agree with Kathy that we don't want to take ideas off the table because premium support is somebody's solution and that we need to hear them out. I mean, that's just the way you have to have conversations on policy. Nobody runs, nobody has the market on ideas. And so we do have to listen to everybody. And premium support has, it has some qualities to it that are important to some folks. It's a pretty big reform. It's major reform, I would call it. It's, it doesn't get any bigger than that. So that's kind of, it gets in a different bucket. But I think we should be listening to each other's ideas. I think that we need to scope the problem because we could make the problem bigger and bigger and bigger. We could make it, Medicare could all of a sudden be, well, how do we fix healthcare costs? 3.8 trillion. And that's a kind of boiling the ocean sort of exercise. And that's going to be very difficult to do for any body of, legislators. So I would hope that we're going to be able to at some point scope the problem. And once we do that, then we'll know what solutions fit into that scope. But until then, until we scope the problem, we shouldn't turn away any ideas. Except for the one I mentioned.
We're wrapping up in a few minutes, but before we do, maybe one final question that I'm going to build off something Paul submitted, and maybe just 30-second answers, Amy, Stephanie, Sean, and that's this. Is there one area of Medicare, understanding that there are many, but one area beyond prescription drug spending that you believe is most in need of reform? Amy, then Stephanie, then Sean.
So I think I wouldn't call it reform, and here we go. I'm not going to be 30 seconds again.
You might have to be.
I wouldn't necessarily call it reform, but our job in Congress is to be good stewards, as Sean started her presentation by saying, is to be good stewards of the Medicare program. And there certainly are, a number of areas in the program that we know we can be more efficient. We can deliver better care. We can deliver, that care with more accurate payments and better align incentives. So obviously prescription drugs, as Paul says, is one of them. Another question might be Medicare Advantage, right? There are longstanding MedPAC recommendations that haven't been implemented. There are some questions about Medicare Advantage organizations coding for, severity, complexity of cases, but then are those services being delivered when you look underneath the hood, right? Kind of what's going on there. You can look at, when I was looking at the list of blogs on Commonwealth, somebody raised the issue of we've got a PAC system that's been posting 10% margins for the past number of years, 10, 20 years. So there's probably something that can be done there to realign payments to deliver a better value for the program and better care for the patients. I mean, there's just a few ideas that come off the top of my head.
Just a few. Stephanie, is there one area that you think
I think interesting, something we learned from COVID is the rise of telehealth. I think it's been something that we've always kind of looked around the edges, had different kinds of scores, didn't know about waste, fraud, and abuse. Now we have a natural experiment. We're going to get more information from MedPAC and the OIG, and it'll be fascinating to see, what worked well and what didn't over the coming years.
And Sean, what's your pick?
I only get one. That's going to be that's too hard. So if I was going to pick one, I guess I can't pick one. I just can't. So I really agree with, I agree with both of my colleagues. I agree on telehealth is something that is innovation that we need to really figure out how it works well for the program. I completely agree with Part D reform. It's a really successful program and super important to people's lives. We need to figure out how to make it more efficient and the benefit design more modern, let's call it modernized. And I think post-acute care is an area where we need to take a good look at this. There's quality issues there, there's payment issues. So we have no shortage of areas where we need to take some serious looks in Medicare.
In the movie Aladdin, the Disney movie Aladdin, the genie says, you can't make a wish to have more wishes. And maybe I should have made that rule. The one policy answer can't be all the policies. But the one wish perhaps is that we should do this again in a longer format, because there are so many pieces of Medicare and policy that we didn't get to cover. I did learn that Sean wants to never talk about raising the age of eligibility again. Also premium support drew some eyebrow raises. But thank you to you three for making time, and thank you to the panel earlier as well. I hope this is a good primer as we get back into issues that are not specifically COVID, and Medicare is about the biggest issue in healthcare today. So thank you to you three. Thanks to the other panelists. Have a good afternoon.